الأطفال ورئيس قسم أطفال المستشفى الجيش العسكري المعادي. ودلوقتي يسعدنا إن احنا يكون معانا الأستاذ الدكتور وليد فرج عزت، أستاذ في أذن محجرة طب عين شمس. will give us a lecture about tracheostomy problems in neonates.
Okay, thank you, Doctor. Actually, I'm just going to highlight a few issues concerning neonatal tracheostomy. Of course, the tips and pearls I want to highlight. Actually, there is something called the tracheostomy and there is something called the tracheotomy. And the main issue is that if you're going to have to remove part of the anterior wall of the trachea during surgery, that's creating an ostomy, that's creating an opening. And we really don't like to do that in such young children, and even in children we don't like to have a defect in the anterior wall of the trachea, because bottom line, even if it heals properly, it's going to heal by fibrous tissue, and this fibrous tissue is definitely much weaker than what God created, which is the cartilaginous skeleton. So these children later on are more liable to problems with this area of the trachea. It's more liable to have some sort of tracheomalacia later on. It's more liable to have infections. It's more liable to trauma later on. So really, if we can perform a tracheotomy, just an incision in the wall of the trachea, we do prefer that. Of course, what's the preference of an ostomy over an otomy, or an otomy over an ostomy? That's surgical issue, because if you can have an ostomy, it's much safer, because you do have a defect and you usually secure this defect in the tracheal wall to the skin or the subcutaneous tissue, and everybody knows his way even when the tracheostomy tube is not in place. But when I have a simple otomy, just an incision, okay, if the tracheostomy or the tube comes out, everything just collapses back in place, and you will have a very difficult time finding your way back into the lumen of the trachea. So you have to find some way else to secure your airway, and that's the stay sutures that Professor Brian said, that we can take a suture on the right flap and the left flap and just secure them to the skin, so that if the tube comes out or you have to change it, you just hold the stay sutures and you have your pathway apparent again, even without any surgical assistance. The timing of the intervention, tracheostomy or tracheotomy, I think that we have strict indications for an immediate tracheotomy or a tracheostomy, whatever it is, whatever the indication is, and that's with some of the congenital malformations. With that, sometimes you can even diagnose prenatally. I mean, if we have a good ultrasonography of the child, and then you find that he has a congenital malformation that will necessitate immediate intervention, you can even perform such a tracheostomy or a tracheotomy with the cesarean section, even before clamping the cord. If you have something like severe sublotic stenosis, or even aplasia of the larynx, sometimes we have aplasia of the larynx, a total aplasia of the larynx, or a total sublotic stenosis. That kid, if you just clamp the cord and deliver him out, you won't have time even to perform the tracheostomy, because what will happen is that, all right, the pediatrician will find out that the patient, the kid, is not taking his breath. What would you do actually? Without an ultrasound, you'll try to intubate. Okay, there is nowhere to intubate. So you'll try for 20 seconds, for 30 seconds, for 40 seconds. I can't find the lumen, because there is no trachea, there is no larynx actually speaking, or even if there is a malformed larynx, there is no lumen, whatever small it is. So that kid will definitely die. But if you diagnose him prenatally, intrauterine, you can plan to perform a tracheostomy by a cesarean section before clamping the cord. You can have, I think you've done that a couple of times. We haven't done it yet. Yeah, okay. So really, when you're considering with the preoperative assessment, you stress, if you have a history of something like that, please stress on the ultrasonographist, please find how the trachea is doing, and if I have any query sublotic stenosis or so. And definitely you should ask for help as soon as possible. Something else I want to highlight, there is nothing called a contraindication for a tracheostomy or a tracheotomy. Whatever the weight of the child, whatever the condition of the child, whatever the condition of the mother is, there is nothing called there is a contraindication for. So even if he's got whatever, nothing's called a tracheostomy contraindication. Even in children, even in adults, whatever. So, what are the differences between having such an intervention from a child to an neonate to an adult? Of course, the anatomy of each of these, an infant and a child and an adult, is different. We've got a much larger occiput in a neonate than in a child, than in an adult, so that will hinder your visualization of the neck a little bit. So you have to have more extension and more elevation of the shoulders of the kid. That's our problem, of course, but even you will have the problem while intubating the child. I think you've got to have more extension. But please, just put in mind that while you're extending the patient's neck, don't overextend it. Not because you will not find the proper airway, because if you have a congenital malformation like a patient with, let's say, not even congenital malformation, like the Down syndrome, okay? It's got a lax S1 and S2, lax vertebrae, so you can very easily dislocate him, and then you'll have a bigger problem than having an airway problem. Yeah. So you have a bigger problem, not only airway. Okay, you can have a large goiter. How are you going to manage a large goiter? It's our problem and your problem. That large goiter may compress the trachea completely, so I have to have it pre-planned. Okay, that case, maybe I can perform an endotracheal intubation as a start, but it will never work for long term. You'll have to intervene immediately for tracheostomy for such a case. Another issue is that please put in mind that tracheostomy in a neonate does not solve the problem. We are obligate nasal breathers by inheritance. So God created this obligate nasal breather. So if you bypass this obligate nasal breather response and tell the kids, okay, you've got much easier airway here from your tracheostomy directly, you will have very hard time weaning them. So please, when you're performing tracheostomy, put in mind that we're obligate nasal breathers and we should return to being obligate nasal breathers by time. Something else, in comparison from a neonate to a child to an adult, you'll definitely have a larger tongue in a neonate than in an adult in comparison to this whole airway pathway. So neonates have relatively larger tongues than kids, than adults. So I have to put that in mind during intubation and during performance of tracheostomy. Okay. And the larynx is definitely higher placed. Does this make a difference? Yes, because I'm going to show you in a couple of slides that when we're performing tracheostomy, we try as much as possible to be away from the cricoid cartilage, because if you are performing surgery and you're performing a tracheostomy and you injure the cricoid cartilage, that's a disaster, because you will end up in 90% or more with a sublotic stenosis that's even more and more difficult to treat. It's going to need more extensive surgery, not only a tracheostomy later on. And of course, the kids have a more anteriorly angulated vocal folds. And actually we call it folds with cords now, because it's a fold, not a cord. Okay. So just to show you that there are differences in the anatomical relationships between children and adults, about the position with the tongue, about the position of the larynx, and about the position of the pharynx itself. All right. And of course, everybody knows that we have different shapes of the larynx, and the shape of the larynx is different from a neonate to a child to an adult, of course. And in all of us, in everybody, the narrowest part in our whole airway is our cricoid part, because that's the only complete cartilaginous ring. Okay? So this is the difference. All right. If you can see here that the newborn epiglottis is like an Indian 8. Okay. It's not actually in Arabic, it's an Indian number 8, all right, it's an inverted V shape, and this is in a child, and the other one is in the adult. So definitely that will hinder the normal pathway of air a little bit. And if you have edema or something like that, it definitely will affect newborns more than children, more than adults. And this is a picture of a newborn, a normal newborn, okay, with the inverted V shape, and this is a normal adult. See the difference between the brackets. By the way, this is not laryngeal malacia, because sometimes you will see in some slides that this is laryngeal malacia. This is not laryngeal malacia. Okay, that's a normal epiglottis in a neonate. And something else, as we told you before, the shape of the larynx as all is different in children than in adults. Of course, in adults it's almost straight tube, but in children it's like a funnel. And that produces more problems because it's more liable to obstruction. Okay, and everybody knows, I don't know if I'm pronouncing it right or no, it's Poissonier's law. How do you pronounce it? You don't pronounce it. Okay. Yeah, okay, whoever he is. I mean, because we know that the smaller the diameter, the more disastrous an edema can be. Because the law says that there is a big combination of like that. But I mean, the bottom line is that if you got 1 millimeter edema, just 1 millimeter edema from infection or allergy or whatever, in an adult, it will reduce only 44% of the airway. But if you have got 1 millimeter edema of a neonatal airway, it will reduce 75% of the airway. So it's just 1 millimeter edema. So you find out how fast a kid with a respiratory tract infection can go into stridor and can go into respiratory distress. So that's why we actually take a decision for tracheostomy in neonates and in children much faster than taking it in an adult. We don't wait until the adult, we don't wait until the child is cyanotic until we do a tracheostomy, because we know that within a couple of hours he can go into cyanosis and can go into complete airway obstruction and can go into death. But in an adult we can wait maybe hours and sometimes days waiting for him to improve. But in children, once you think of tracheostomy, once you think of it, this patient may need tracheostomy. Please perform a tracheostomy. It's much safer to have a tracheostomy, if in doubt, than not to have a tracheostomy. You will never lose with a tracheostomy, but you might lose without a tracheostomy. Okay. In general, the types of tracheostomy are the percutaneous dilatation of tracheostomy, and actually that's not nice at all for neonates. Do you have any percutaneous for neonates? We don't do it for neonates. In children, maybe. In adults, definitely. But it's not nice at all for neonates. It's time-consuming. You don't have the lumen enough, and you actually squeeze the tracheal rings up and down, not laterally, but you squeeze them up and down, and that produces more trauma. And with the funnel-shaped larynx, it's not possible to have it with a safe procedure. So we don't perform a percutaneous dilatation tracheostomy in neonates. We relatively rarely do it in children, but we do it in adults. So how about the standard surgical? Actually, we have two schools. If you're going to have a skin incision with a vertical or a horizontal skin incision for the tracheostomy. Each one has its pros and cons. How about the vertical incision? Of course, the vertical incision in the skin is very nice in that you have all the incisions, skin, subcutaneous tissue. If you're going to divide the thyroid isthmus or something like that, and even the trachea, all of them are incised in the same plane. So it's quite easy to find your way even while extracting the tube. But that's disastrous for the cosmosis. You'll have a very, very, very bad scar because you're going against the normal lines that got created. So what we actually do now, it's a little bit more difficult technically, but it's much more suitable, that you have the skin incision vertically and then everything else the skin incision horizontally and then everything else vertically. So that when you extubate the patient, he doesn't have an ugly scar. Okay? So only the skin incision is done horizontally and then everything else is done vertically. And as I said, the decision of otomy and ostomy is a little bit controversial, but we do prefer an otomy, not an ostomy, in neonates and in children. Okay. When was the first tracheostomy done? We've got literature in the Islamic old books. This is Marwan Ibn Zahr, Abd Malik Marwan Ibn Zahr, which was in the 10th century. He published a book about tracheostomy, and even earlier than that, the artifacts from ancient pharaonics say that they've had some sort of tracheostomy done, even in low social classes. This is not a king's tooth artifact. This is low class artifact. So we have some sort of tracheostomy done even in ancient Egyptians. Okay, as I told you before, that you can have an indication prenatally, something like a congenital atresia or stenosis, if you can diagnose it properly by a proper ultrasound done early. Immediate neonatal indication. I mean, you did not diagnose anything else before, but immediately when the child was born, you could pass a few minutes and then, okay, I will need an emergency tracheostomy now. When is that done? If you have a congenital malformation of the neck, like a huge goiter compressing on the airway, and you cannot do a proper endotracheal tube and secure the airway, or a huge vascular or lymphatic malformation, like a huge cystic hygroma or something like that. And something else that, thank God, we rarely see now is a bilateral vocal fold palsy. Maybe I attended the very end of having a bilateral vocal fold palsy after traumatic injury of the vagus nerves and the recurrent laryngeal nerves from tough delivery. I mean, we no longer now have forceps delivery, but maybe 25 years ago, there were still forceps delivery, and the forceps delivery sometimes can compress your head and do like that, and you're squeezing the kid outside, so this shearing action can actually injure the vagus nerve at the skull base and produce bilateral vocal fold palsy. I've seen a couple of them maybe 25 years ago or so. Or you can have something congenital producing bilateral vocal fold paralysis. Okay, you can put an endotracheal tube, but you can't live with an endotracheal tube. It's something permanent. You have to have a permanent tracheostomy. So at that time, we can't perform a tracheostomy. So it's going to be permanent until you have a final management of this bilateral vocal fold paralysis. And then, of course, later on, if this kid develops some sort of respiratory distress syndrome or a severe infection that's obliterating the airway or closing the airway and intubation is not enough, you can, at that time, perform a tracheostomy. All right. As Professor Brian said, what is the time limit between having an intubation and then deciding for a tracheostomy? I'm going to say again that how long do you expect the endotracheal intubation to be? In adults, it's very easy. The cutoff point is 10 days. If you're going to have an endotracheal intubation for more than 10 days, on the 9th day you consult the otolaryngologist, on the 10th day you perform the tracheostomy. Except if you're predicting it from the very beginning. I mean, let's have a stroke, it's going to have a major surgery, something like that. Okay, from day one I can perform a tracheostomy. But how about in children and in neonates? It's much earlier than that. Actually, here we try to implement the 48-hour rule. If you're going to have an endotracheal intubation for more than 48 hours, it's much safer to have a tracheostomy as early as possible. Why? Because this airway is much more liable to injury. And even having surgery for more than 6 hours injures the airway. I mean, we've got plenty of studies saying that if you intubate him during surgery, for tonsillectomy, for a thyroidectomy, for abdominal surgery, for whatever, the cutoff point for injury of the mucosa of the airway is 30 minutes. If you have any intubation for more than 30 minutes, there are superficial ulcerations in the mucosa of the larynx. You have superficial ulcerations in the mucosa of the trachea. So actually, after 30 minutes intubation, you start to have initial problems. Okay, most of them heal if you're going to remove the tube within 48 hours, but some of them persist. So please, if you're going to have an endotracheal intubation for more than 48 hours and you're still planning to have it more and more, even from the beginning, you can order for a tracheostomy or a tracheotomy. Okay? In children, maybe we can wait until 4 days, but not more than 4 days, please. I don't know how you do the cutoff points in the USA.
Much longer.
Much longer. And how do you deal with the granulation tissue that is always there after 3 or 4 days?
Then we have an indication to do a tracheostomy. Because they got stenosis.
We could get parents to agree to that.
You could.
We could not get parents to agree to intubate a trach neonate in 48 hours. I mean, sometimes we're intubated for months and we can't get them to agree to tracheostomy. They do not want to.
I'm with the French school, by the way, because I learned in France. I mean, the standard is if you're going to keep the kid for more than 48 hours in France, I don't know what you do in the USA, but in France, if you're going to keep the kid for more than 48 hours, you have to have an endoscopic examination during extubation. Okay, because if you find any sort of granulation tissue or any sort of injury apparent, then you'll have to tell them that I'm going to put it back again and I'm going to start steroids, inhalational and systemic, and try to control the granulation.
Actually, it is not written in any guideline to use the tracheotomy or kera.
In pediatric guidelines or in ENT
No,
guidelines? Oh, no, okay. Okay, I'll get you from the ENT point of view, definitely for that. I can get you documentation that in France and in let's say half of Europe, they tell us that if you're going to keep him in a neonate for 48 hours, please perform a tracheostomy as early as possible. I can get you the reference. There's no question. So I want to tell you something else, that the site of obstruction and site of problem is really difficult to diagnose if it's lower than the level of the vocal folds. I mean, you can have a stridulous neonate that's coming to you with, let's say, biphasic stridor. That's difficulty during entrance and exit, and then you say, okay, where is this obstruction? It can be immediately in the cricoid area or in the upper trachea, or it can be lower down. So that's why if you have something like a biphasic stridor that there is difficulty in and out, please perform an endoscopic examination before deciding on a tracheostomy, because you might find the stenosis or the obstruction even lower down than you can reach with the longest tracheostomy lumen. Because we have a standard tracheostomy length, and then sometimes you can order for a long tracheostomy. It's very difficult to have a long tracheostomy thereafter. Of course, Professor Brian showed you that there are several types of tracheostomies, but my concern is that not the type of tracheostomy, but I mean if the tracheostomy is fenestrated or not fenestrated. That's very important in our point of view as ENT surgeons. Because if you have a non-fenestrated tracheostomy, then the only pathway for air is through the tracheostomy. It's only from outside to inside. But if you have a fenestration here, okay, this fenestration is actually where the larynx is. And we really do prefer to have a fenestrated tracheostomy tube inserted, so long there is no aspiration. So long you have a normally functioning larynx, so long you have a normally functioning upper aerodigestive area, please, we prefer to have a fenestrated tracheostomy, because such a small lumen of tracheostomy does not permit any air to escape between the tracheostomy lumen and the tracheal wall. So you will not be able to wean the child easily. But if we have a fenestrated tracheostomy tube like that, we can start to wean him without changing the tube. Because you have two modes of weaning. You can either wean with the same tracheostomy tube by partial closure of the external opening, or you can reduce the size of tracheostomy gradually. And we don't like to do that, actually. We like to keep the same tracheostomy tube, but have a fenestrated one, and then start to close it gradually from outside.
Do we have it here?
Yeah, we do.
Neonatal side?
Starting from 3.5, we have Indian made. Okay, and starting from 5, the international brands. But it's quite expensive, actually, in Egypt. And you have to specially order it. And I'm going to show you just some indications. How about this one? That is laryngomalacia. And we actually rarely need the tracheostomy in tracheomalacia, because most of them, you know, of course, more than me, that positioning is usually more than enough in 95% of the cases. And even if positioning is not enough to control it, we have surgical options other than performing a tracheostomy, which is we do something called an epiglottic fixation or epiglottic hanging. We just take a stay suture from the tip of the epiglottis to the base of the tongue, so that you keep it elevated all the time. Sometimes we have laser partial epiglottectomy. We can just remove part of the epiglottis. Sometimes we have lysis of the epiglottis itself. We have other options. We rarely resort to tracheostomy in laryngomalacia. But something like this second slide with a subglottic, sorry, this is a glottic stenosis. This is a congenital glottic stenosis, and of course a much more severe one, and that's a post-intubation subglottic stenosis. That kid down there on the right-hand side was intubated for only 11 days. And on extubation, that's the picture we found, because they extubated him after 11 days, and then he had a severe stridor, and they had a very difficult time reinserting the endotracheal tube. So, come and help us, please. And that's the picture there. And that's why 2 days, 3 days is the maximum in our practice here. Maybe you have more infection, I don't know. And of course, how are you going to care for the tracheostomy cannula? Of course, what we recommend is that, especially in the first 3 or 4 days, there is regular suction every hour. But please, I know that some keen residents and keen nurses are over-vigorous in suctioning. So what's the proper technique of suctioning? I mean, you should know the length of the tracheostomy, and you should not push the suction tip for more than 1.5. Sorry, that's quarter inch. That's maybe 3 or 4 millimeter beyond the tip of it. Don't push. I don't want it to push down into the carina, into the bifurcation, because that will injure the mucous membrane of there, and you will induce more granulation tissue formation, and you will induce more stenosis even lower down. So that's going to be a big problem. So please, you should know the length of the inserted tracheostomy tube and just push the suction tip for 2 or 3 millimeters just beyond it to be sure that you have passed the tip of the tracheostomy tube. And of course, if you have inserted an inner and outer one, like the one I showed you here, like that, it's much easier. Why? Because all you have to do is remove the inner tube, clean it outside, and then you can reinsert it again. It's much more safe for everyone. Sorry, okay. And then you have to use humidified air, please. You have to use some saline every now and then. And of course, you have to take care of the wound until it's fully formed. And as I said before, it's an otomy or an ostomy according to the indication. And be sure that if you're going to have an otomy only an incision, you should have space sutures. Okay, when is the first time you can remove the tube? If everything is fine, everything is going smoothly, and you can clean it, and the airway is patent, and everything is going fine, you can remove it after a week or so. So this is the way you perform the suction. All right, the patient should lie down, a little bit extended. You insert the tube, because something else that was a wrong procedure is that you have the suction working and then you close completely. You close completely the suction catheter, and then you introduce it closed completely, and then you release the suction, right? That's what they taught you. That's completely wrong. Of course, there is a valve in the suction, so if it's minimal suction while going inside, and then you close the valve and then you suck while coming out. But don't suck completely while going in, and don't close it completely while going in, because we need to suck what's in the way. I just don't want to push it inside. Okay, but if you're going to close it completely and there's something in the middle, then you're going to push it inside so you can produce an aspiration of something. So don't do that. Just the minimal suction while going inside, and then you close the check valve of the suction, and then you pull it out. So, pardon?
As we do in meconium suction.
Yeah, that's great. All right, you do exactly the same here, because we don't want to push any mucus plug inside, because if you push it inside, it might produce more problems, okay? And this should be taught to the mother from the first day, by the way. The cuff. If you're going to use an endotracheal cuff, a tube with a cuff, it's very important that the cuff pressure, of course, every company has its indications for the cuff pressure, and that if you can avoid using the cuff totally, it's even much better. We don't have cuffed endotracheal tubes below 5. Even the inner and outer, we don't have sizes less than 5 with a cuff. So that's very important too. Actually, you rarely need it in neonates. You rarely need a cuffed endotracheal tube in neonates, because it's always just as the size of the trachea. And of course, wound management. Actually, we use betadine here in Egypt for, let's say, 4 or 5 days until the wound starts to heal, and then later on we can use just what we do recommend is panthenol cream every day, so to avoid any ulcerations in the skin. So how are you going to replace the tube? As I said before, what we do here is 5 to 7 days, a first trial of extubation and removal, and then reinsertion of a new one. And that new one, yes, we can leave it for up to 4 weeks. But we prefer to remove the first one after 5 to 7 days. And then if you're going to keep him for more than that, yes, you can keep the second and third and fourth every month or so, or something like that. Of course, percutaneous tracheostomy is not done in neonates. Why do we wait the 5 to 7 days? Why do we wait the 5 to 7 days? That's the rationale, because that's the optimum time for having a tract developed there. Okay, so how I'm going to wean from the tracheostomy? We just
we don't just pull it out and then, okay, he's weak. That's a disaster, of course, because as we said, the kid has got used to taking his breath from a much easier pathway here. Instead of going from his nose to his throat, and then from his throat to his larynx, and then from his larynx to his trachea, he's got a shortcut airway, and really kids are very dependent. So if I find a very short way, why should I depend on a very long way? So what we actually do is we start, of course, if it's not a fenestrated endotracheal tube, you have to fenestrate it or put a fenestrated one. And then after that, you gradually close the external orifice of the tracheostomy. What we have, sometimes we have a tracheostomy closure cap that is 50% closed, and then it's 75% closed, and then it's 100% closed. But of course, you should do that under strict observation. Okay, but is that it? If I close it completely with the check valve here, and then the patient can withstand it through the fenestrum, is it okay? No, that's not the end of the story. Because what happens is that a few patients have some sort of weakness and malacia of the trachea after tracheostomy, especially if it's going to be long-term for 3 or 4 or 5 weeks or something like that. And of course, definitely it's higher incidence if it's going to be there for months. So, okay, I have closed the ostium from here, and the patient is having his breath fine from his nose, through his pharynx, through his larynx. And then I start to try to remove the tracheostomy, and then he suddenly develops stridor. What has happened? He's probably had some sort of tracheal malacia, and when I remove the tracheostomy, there is a collapse in the wall of the trachea. So I have to reinsert it again, and then please, you should order for an endoscopic evaluation, because sometimes we do have something like that with a tracheal malacia that's so severe that it just collapses with the negative pressure that is needed for inspiration. What's the solution? It's a very bad solution, that you have to put a stent inside. It's a stainless steel stent or a silicone stent, according to what we use, and all of them really have lots and lots of problems. So the best thing is to avoid it. But we have solutions, of course. And of course, we should know that since in neonates we have smaller sizes of trachea, and you have to use a smaller size of endotracheal intubation and tracheostomy, the incidence of this tracheostomy being in direct contact with the tracheal lumen wall is much higher. So it really affects, and if you're going to use a cuffed tube, that's a big problem, because you are depriving the mucous membrane and the tracheal wall from its blood supply. So you will have more and more instances of tracheal malacia with long-term tracheostomy in neonates than in children, and in children than in adults, of course. So please be aware of this point. We don't want to use any cuffed tubes as much as possible, and we want to use as short as possible. And please take care that when you are weaning the patient, you should put in mind that he might have some sort of tracheal malacia present. Okay. Another issue is that we don't want to squeeze the tracheostomy inside. If you're having problems, use a smaller one. It's better than squeezing a larger one inside. Okay, because as Professor Brian said, okay, as ENT surgeons, you just want to fill the tracheal lumen. It's not that right. We always want to have some a millimeter or so surrounding the tracheostomy, so that there is some air coming out and giving some space for the perfusion of the mucous membrane of the trachea. What are the problems that could happen? Of course, early problems, you can have immediately after surgery some sort of occlusion. From few minutes to hours to days occlusion. That can be a mucus plug occlusion, can be some blood clot occlusion, all right? But more important is the misplacement. If the tube comes out of the trachea as in just in between the soft tissue of the neck, how are you going to diagnose it? There is no air entry at all, and no airflow at all, of course, and the patient becomes cyanosed again or something like that. And then if you try to insert your catheter, it will just go into blind end. Okay, so please revise it. Of course, what helps this is that if you're not securing the tracheostomy inside, we like to secure it with tapes for the first 3 or 4 days. Okay, wrong neck positioning. I mean, if you're not fixing it and the kid is too much moving like that, it might induce a displacement of the tube. Something else is that if you're not giving the right size of the tracheostomy, what happens is that sometimes the tracheostomy itself can be kinked inside the trachea. I mean, it should be like an inverted L shape. So if I'm going to kink my head like that, sometimes the bevel of the tracheostomy hits into the anterior wall of the trachea or the posterior wall of the trachea and becomes partially obstructed. So just, it's inside the trachea, it's in proper position, but the side is not right, so it's kinked inside the trachea itself. Okay? Another issue is that you might find the patient complaining of dysphagia after performing the tracheostomy. That could be due to two things. Either you are inflating the cuff, and this cuff is preventing the proper peristalsis of the esophagus and things like that, or, which is more important, is that you are fixing the stitches in the neck too much, and this is painful. All right, it's painful. When you swallow, everything goes up and down. Right, everything goes up and down during swallowing. So if you're putting too much strain on the stitches in the neck, that might induce some dysphagia also. Of course, bleeding is a probability if you're very close to the thyroid gland. Of course, here in the kid, the neck is that long. You can have the innominate vein, you can have the carotid, you can have anterior jugular. Things like that can be eroded from infection post-operatively. And of course, wound infection is a big disaster because you will have neck sloughing of the skin, and of course, you can injure some blood vessels also. Later problems, as I said before, you can have decannulation problems like difficult weaning from dependence or tracheomalacia or something like that. And something else that can happen is sublotic stenosis. It can happen from a tracheostomy, yes, of course, in a much less incidence than with an endotracheal tube, but it can also happen with a tracheostomy, especially if the size is not right and there is always some sort of friction between the tip of the tracheostomy and the tracheal wall. It can use some sort of granulation tissue, and this granulation tissue can turn into fibrous tissue, and this fibrous tissue can turn into a subglottic stenosis, which is very difficult, and as I mentioned before, you can have amalacia. And of course, a very important and disastrous complication is that you might have a tracheocutaneous fistula. That's not a problem. The tracheoesophageal fistula, that's the huge problem, and they just put a comic like that. You will do like that. Okay? And this is another Arabic comic. Okay, so any questions? Okay, thank you very much. By the way, for your interest, we have the second Pediatric Otolaryngology Congress from the 2nd to the 4th of November this year, inshallah. It's going to be here in Cairo. We're going to have a session for pediatricians. So I'm going to send to Dr. Rania the flyer. If anyone would like to contribute, he's most welcome. Thank you very much.
Thank you very much, Dr. Waleed. في الحقيقه انا هبدا اقدم براين النتائج، بس قبل ما اقدمهم هتكلم ان انا اشكر دكتور هشام عوض على دعوته في عيد ميلادي ان انا تبقى تشير بيرسون في هذا المؤتمر، والتعاون الهائل اللي بين شباب القوات المسلحه واسم اطفال جامعه عين شمس وبالذات نيوتال. تقريبا شهريا عندنا تقريبا رساله مع الدكتور سامي الشيني عن دكتور هشام عوض بنناقشها وبنعملها في نيوتال في عين شمس. Thank you very much for the invitation. وثانك يو فيري ماتش للدكتوره رانيا، في الحقيقه عامله مجهود هايل والانثوزيازم بتاعها هايل، وده انا كان سبب نجاح اي ميتنج بتتعمل ان احنا بنحاول نعمل ابجريدنج للكوميونتي بتاعتنا على مستوى الانترنت. ثانك يو فيري ماتش. Now I would like to present Professor Natali and Professor Brian. Actually, each one we have seen them, but now we'll see them together. I don't know how they will make it, but we'll see. Thank you very much.
So we decided to change things up a little bit because we've been talking to you guys for several days, and we've already reviewed quite a few interesting cases and a lot of the studies and different talks that we're thinking of trying to discuss with some of these cases. So we thought it might be more interesting and beneficial to just have more of an open discussion about questions that you all might have of some of the things that we've already discussed, and it doesn't really even need to stick to advanced modes of ventilation that we had put for this. What do you guys think about that? I saw a lot of head shaking. So good. So are there any questions? Did you want to say anything?
Yeah, well, we'll start with a couple cases just to get your mind going. And what I mean by that is that we've kind of negotiated some cases that we were thinking about presenting and decided to kind of open it up to you guys. And so one of it is a preterm infant. Let's just say they're extremely preterm, 26 weeks gestation. Let's discuss, for those of you that have high frequency ventilation, using it proactively versus rescue. What are your thoughts on that? For you guys that don't have it, unfortunately, you don't have it, so it's harder to make that decision. And so what are your thoughts? Are you for it, against it? In your experience?
Yes.
Yes?
Yes.
Yes for it?
Yes, I'm for it, especially below 1 kilogram.
Okay.
Usually in these patients, we are using CPAP really, and we can use insurance technique if they have oxygen requirements above 30 or 40 according to gestation age, according to the European consensus recommendations. And if you are going to intubate these patients, I prefer in patients below 1 kilogram to put them in high frequency proactively. And I'm doing the recruitment maneuvers, and then I'm giving surfactant. I prefer to do recruitment before surfactant administration. So you are starting with an open lung to homogeneously distribute surfactant, and then you can go down by pressure. And in some cases, after giving surfactant, you are ending with a very low pressures, and you are going to keep them on a low settings, and you can extubate them rapidly.
Do you extubate them straight from high frequency?
Yes. Yes, I go down by the mean airway pressure up to 8 and extubate them to CPAP. But sometimes with very low birth weights, 700 grams, something like this, I had a couple of cases that they have been on a low pressure, but when starting to one case I disconnected them, but they had severe respiratory effort when they are put in CPAP. They are doing the tube, and in the second case I leave them on the ventilator for more 1 day before extubating, except unless they are showing good respiratory effort.
Do you feel like your outcomes are good because of that strategy? Do you feel like your outcomes are good because of that strategy? Not to put you on the spot.
I don't have much experience. We don't have these cases, a lot of these cases, below 1 kilogram, but I think in my experience it was better than putting them on continental.
Great.
Especially
anybody have a con to that? In other words, that you would only use it for rescue? I'll take the con.
It would make a difficult case for me.
No, just to have the discussion, because I mean, we often debate this same philosophy, and then when we combine high frequency ventilation with other therapies that we think are beneficial, like kangaroo care or skin to skin, it becomes much more difficult to manage those patients, at least with our high frequency system, which is more stiff circuit and a little bit more difficult than conventional ventilation. And so the other things that we lose come up some of our assessment skills, and so it's hard to assess breath sound.